Mars with the night apartment and stuff. So can I call you like?
Good afternoon, everyone. I'm Winslow Woodland, Deputy Director for the DDS Developmental Disabilities Administration. Today I'm sitting in for Director Andrew Reese, and I'd like to welcome you. I will begin with the statistics on the coronavirus. As of yesterday, we have had 252 people test positive for the coronavirus, 4 of which lived in host homes, 86 who lived in ICFs, 24 who lived in natural homes, 2 who lived in nursing homes, 27 who were in residential habilitation settings, 109 who were in supported living settings. Currently, we have only 1 person hospitalized, and to date, we had we have 1 person currently hospitalized. We have had 136 who did not require hospitalization, 82 who have required hospitalizations, and sadly we have had 33 people who have expired as a result of this virus. With regard to provider staff, to date we have 322 who have tested positive, 29 of those who have worked at multiple providers, and we have a report of 9 deaths by provider staff, but the caveat to that is that 1 provider reported the death of the same person twice, so actually only 8 people have actually died. In terms of monthly breakdown, we had 5 cases in March reported as positive, 137 in April that were positive, 43 cases in May were positive, 16 in June were positive, and then we saw an uptick in July of 26 people who were positive. In August, the month of August, we had 17, and to date for the month of September, we have had 8. In terms of death, we had 0 in March, but it was partial month of testing. In April, we had a total of 18 deaths. May, we had a total of 8 deaths. June, we had 1 death. We had 3 deaths in July, and the month of August, we've had 3. And thankfully, for the month of September, we have not had any. I'm going to move into some issues that were open from last week's call. There was a question as to whether IDS required a reopening plan. It actually does, but the requirement for IDS opening plans are much less comprehensive in terms of there are 3 responses that have to be answered. The deadline for those reopening plans is Friday, September the 25th. We've reached out to, on another open item, we have reached out to the DC Health Board of Nursing regarding the TME testing, and we have since learned that the vendor is opening up additional testing sites, and that the vendor will be offering online testing for TMEs. To date, we have day program approved providers. As of to date, we have 9. They are PSI, Art Enables, Metro Day Services, Excellent Community Services, Bridges Day Services, UCP, Superior Helping Hands, Brookland, and Global Resources and Supports. I know I jumped from the testing to the number of providers that have approved day program plans. There are 9. And we also had information that was requested regarding the retainer payments for day providers. I just want to let you know that our department has submitted a format for approval to the DC Healthcare Finance. We have not yet received that approval. However, that does not mean that a provider cannot submit an attestation. So I'm just going to go over what the requirements for attestation. A provider must attest to understanding that retainer rates will be subject to recoupment if inappropriate billing or duplicate payments for services occurred. 2, the provider must attest that they did not lay off staff and maintain wages at existing levels during the period represented by the retainer payments. 3, a provider must attest to not having received funding from any of the sources that would exceed its revenue for the last full quarter prior to the public health emergency, i.e. October 1 through December 31st of 2019. 4, the provider must attest to not having received unemployment benefits used to reimburse staff wages during the period of the retainer payment reimbursement. 5, provider did not receive funding from any source, including but not limited to unemployment benefits and small business administration loans that exceeded revenue for the last full quarter prior to the public health emergency and did not require repayment. 6, provider must attest to that they did not receive funding from the CARES Act Provider Relief Fund. And 7, provider must attest to not having received revenue greater than that of the quarter to the public health emergency, or that retainer payments at the level provided by the state would not result in their revenue exceeding that of the quarter prior to the public health emergency. At this point, I will try to have that information posted into the chat box, and so that if people need to revisit that and want to try to attempt to submit an attestation prior to us getting the format we submitted approved. I'm going to move to my colleague Kirk Dobson, who would like to provide you with an update.
Thanks, Deputy Woodland. I just wanted to give everyone an update on the day programs that have been approved. So far, we've received 22 applications from providers wishing to reopen their day program. So far, 9 have been approved, 1 has been withdrawn, and the others are being, we're providing technical assistance to the others to get them to approval. The providers that have been approved so far are Excellent Community Services, Art Enables, Bridges Center, United Cerebral Palsy, UCP, Superior Helping Hands, Global Resources and Supports, PSI, Metro Day Services, and Brooklyn Senior Day Center, Brooklyn Senior Daycare Center. So 9 have been approved and the rest are still pending. Thank you, Winslow.
All right, we received a couple of questions. I'm going to turn it over to Crystal Thomas to read the question.
Good afternoon, everyone. We have been getting conflicting information from service coordinators regarding employment readiness services. Some service coordinators are saying that all people in employment readiness have to be transferred to RSA job readiness, regardless of eligibility for ER service. Our understanding was that when a person exhausted their ER eligibility, they could continue waiver services if they choose with IDS or companion services. Also, the referral to RSA job readiness was to allow continued service to those people who are living at home with in-home support or in supported living and had chosen not to return to a day provider. The RSA job readiness could be provided as telehealth and would not be considered 2 waiver services being billed at the same time. Some service coordinators are saying that even if a person is provided ER service in the community out of their home at an internship, they still must be transferred to RSA for job readiness. Can you clarify this for us?
What I am encouraged by with this question is that the provider fully understood and listened to our guidance on this. So the provider is absolutely correct. The person does not have to transition over from ER to job readiness, and not having exhausted. And I will remind you that Director Reese's guidance on this was very clear. What we recognized is we had two groups of people: those who had exhausted their employment readiness, who needed additional job readiness services, and those who were being supported in their home around the clock with another waiver provider, and thus unable to receive employment readiness in addition to companion and or any other waiver services. So you're absolutely correct, and I have since developed a communication to send to the service coordinators so that they get this right. And I thank you for sharing with me the names of the service coordinators who, so we can work to enlighten them. Just to say, there's been a lot of changes that have occurred, a lot of information disseminated, and, we have 80 plus service coordinators. So, to hear that only like a couple of them didn't get this right is very refreshing, actually, to me. So we do have additional questions, and they're going to be read by Crystal Thomas.
I would like to get more clarification regarding the Appendix K and the retainer rate for day services.
Without actually knowing what specific clarification, I'll try to generally recap. The purpose of the retainer payment to day providers of certain day services is to ensure the viability of those particular providers once the public health emergency is over. They are people who provide day habilitation one-to-one, day habilitation small group, individualized day supports one-to-one, supported employment, and employment readiness. What this allows for is that anyone who is authorized for these services prior to the public health emergency, that particular provider would be able to bill a percentage of what they would have been paid had the person attended the program. Now, there has also been some confusion around this because I have since learned that people who have had ISPs during the public health emergency may not have had those services authorized. And I also, reauthorized. And I'm also going to clarify that with the service coordination team to ensure that they understand that no day habilitation service that was in place should be canceled unless, of course, the person has opted to not return, or the person seeking to go into another provider. So it's going to be a little dicey and tricky there because if a person decided not to go back to a provider, and when the provider submits the billing for the retainer, if they don't have the current authorization in place, but we'll deal with those individual situations as they come up. The retainer has to be attested to, as stated before, attesting the criteria as set by CMS. Simply put, you can't get money to keep your business open and then bill for a retainer at the same time. So we have, as I stated before, submitted to DHCF a format for you to use as an attestation. But you can, if you choose to, create your own prior to then. Not create, but use the criteria that you're attesting to those 7 requirements in your attestation. Let's see, there was a second part to that question.
That's correct. In regards to assistive technology, this will be available in November. How can my agency apply and get reimbursed the $10,000 for the 5-year period?
So this would have to come from the IDT team coming together and saying that the person could benefit from this assistive technology. You're not just automatically going to get it. unless the person actually needs it. So, do we have additional questions?
We do. I am now going to the chat box. So for those of you who would like to ask any questions, if you can type that into the chat box now. So yesterday's CMS issued updated guidance regarding nursing home visitation. It recognizes the physical and emotional toll that physical separation from family and other loved ones has taken on residents. Among other things, it states that nursing homes should accommodate and support indoor visitation, including visits for reasons beyond compassionate care situations. When there has been no new onset of COVID-19 cases in the last 14 days and the facility is not currently conducting outbreak testing, it is less restrictive than the DC Health's current ICF Phase 2 guidance. Even though DC ICFs are much smaller, 4 to 6 residents, than nursing homes, is DC Health planning to revisit or revise its current ICF guidance? And I'm not sure if DC Health is with us today.
It's my understanding that they were, so if you could, if DC Health is on the line, they could answer that question. But I could generally say that our experience has been when guidance has come from CDC and CMS, it is reviewed and discussed by our partner agency, DC Health, and adjustments have been made accordingly. We don't operate in real time with regard to new guidance, but we'll definitely ensure that our Monday call, we have a Monday call with them every Monday, that if in fact they have not begun to look at the CMS guidance, that I will absolutely make that an agenda item so that we can speak to those things.
Okay. I'm not sure if our host has located DC Health.
So Ms. Sharon McBain's on the line, and she's able to speak, but I don't think she's available. That's the only person I see from DC Health at the moment. I'm sorry.
Okay. Can you repeat the approved day programs and when are these facilities opening?
The approved day programs so far are Excellent Community Services, Art Enables, Bridges Center, United Cerebral Palsy, UCP, Superior Help in Hands, Global Resources and Supports, PSI, Metro Day Services, and Brooklyn Senior Daycare Center. Please contact those providers to figure out when, or to find out when they're going to open. They're approved to open when they have their approval to open, but they have to go through the CPAC process where the people serve. But as to when they actually start services, you have to contact the provider directly. Thank you.
Okay. So in regards to service coordination, since they are working from home, how are they required to get their necessary ISP documents completed and signed by team members? Some service coordinators are requiring providers to complete these documents on their behalf and get them signed by different parties, which is not always possible. How is DDS supporting them or requiring them to have this completed on a timely manner without putting pressure on the provider?
So with regard to documents, I'm not aware of service coordinators requiring providers to complete their behalf. And when you say their behalf, I'm assuming you mean the service coordinator's behalf. And in terms of signatures, we have been working with our IT department to ensure that our service coordinators have the capability of emailing documents and signing using various programs such as Adobe and or Word programs with stylus pens. What we are frightfully aware of is that a lot of our family members do not necessarily have the technology to be able to support us in terms of the turnaround. We've actually had service coordinators who actually have been mailing documents to our family members with return postage because we recognize that people are unable to use their technology to sign. So it's been sort of a complex process, but to the extent that a provider feels burdened by supporting us through that effort, I'd like for them to just, reach out and let me know what they're experiencing, because I have not been made aware of service coordinators using providers to obtain the necessary signed documentation. So if it's a burden, I'd like to know about it, but I'm certain that we can work through this together.
Can you repeat or send the list of 6 to 7 items included in the attestation for the retainer payment? Were those spelled out in Appendix K? If so, where?
Okay, so the attestation, in terms of the Appendix K, I am not exactly, I'm almost certain that it was not. I don't recall it being spelled out completely in the format, but we do know that the Center for Medicaid Services has issued those, through their guidances on the issue. So I'm going to post those in the chat box. I'm trying to do that now. Gotta forgive me, I'm not the most versed in technology, but I will repost them as soon as there we go. Okay, should be coming through to you right. Oh, I wish these things were a little quicker. Okay. Huh. It didn't come up. I'm gonna put it in the chat box as soon as I can get it to paste.
Winslow, I can answer that.
Answer what? They want
The question, it is in the Appendix K. It's in the August 27th approved Appendix K. If you look at, I'm going back between two screens so I can see myself, but if you look at the top of page 10 of the approved waiver, there's language about what needs to be in there. So pages 10, 11, and 12 deal with the retainer and request and require the attestation. The other thing is that it also refers to the COVID-19 FAQs for state Medicaid and Children's Health Insurance Program agencies released June 30, 2020, and there's a lot of language in that document as well, and we can certainly provide that.
Thank you, Mark.
You're welcome.
I was the Appendix K from April and realized I did not print the latest version. So
what we talked about is when we send this out to the providers, we'll make sure that we include both of those attachments so that you can see the attestation form, the approved August 27, 2020 Appendix K, and the FAQs that were issued by CMS on June 30, 2020.
okay, thanks.
You're welcome.
All right, next question.
Does the retainer payment expire with Appendix K or within 90 days? Please clarify when the retainer payment in our Appendix K expires. Okay,
great question. What I failed to mention when I gave the initial statement on the K earlier was that a provider can bill up to 90 days, and that is a day could be 2 hours, a day could be 4 hours, a day could be 6 hours. But yes, there's a total cap of 90 days. And as you know, we've been in this public health emergency more than 90 days. And the second part of the question, remind me again, Crystal.
Sorry, I was speaking with the mute on. It's just for you to clarify when the retainer payment into our Appendix K expires.
Oh, so
That's
the
all.
appendix, the retainer will be throughout you're eligible for the retainer throughout the extent of the public health emergency, or 1 year, whichever comes first. So, you know, the current Appendix K is open for up to a year, but if the public health emergency is called off next week, then the Appendix K then expires. But doesn't mean you can't bill for that if the service was provided during that period of time.
In light of the revelation on the news last night that some of the guidance that has been coming out of the CDC is not advised by the scientists or have gone through the proper vetting by the CDC, how will DDS and DOH, or DC Health, use this guidance? What are providers supposed to follow? I think most of this may have been around testing. I understand an update is due out today from the CDC.
So we, meaning DDS, have to follow the guidelines developed by DC Health. And it's my understanding that DC Health follows closely with what the CDC recommends. We are at the mercy of having to follow our leads. And I did not see the news report, so I'm not certain. As you know, news reports can sometimes be a little inaccurate. I think most assuredly of the guidance that was around these face coverings that people were using called neck, the things that go around your neck. I can't remember the name of them, but you could pull them up over your face, and a lot of people were using those. And then there was some research done that stated that they were worse than regular face masks. Well, it's been since refuted that claim of that research. So, you know, we are at the mercy of the current information of the times, and we trust the CDC. We trust what they say. So if there are scientists refuting that, we'll have to have some discussions and hash that out. And if the guidance changes from DC Health, we'll certainly make sure we support you in making those changes happen.
When will TME testing be available online? There's a great need.
In speaking with Ms. Hampton, who communicated with me late yesterday evening and early today, she should have an answer on those items by the end of the day. So once we get that information, we'll ensure that we share it with you.
On Tuesday of this week, DC Health posted additional guidance for healthcare facilities regarding universal masking and eye protection. We know this is mandated for the ICFs, but does SL and RESHAB fall under this guidance?
So the answer to that question in short is no. And then just in addition to that, we are continually having discussions with our partner agency, DC Health, on this issue to get a further clarification. Because if you read it, it talks about healthcare facilities, and it also talks about medical procedures. So the questions that we have posed is the definition of a medical procedure being, if you're in a home, the ICF, and a person's watching TV, and you're maybe helping with things around the house, that's not technically a medical procedure. So we're seeking further guidance on that. Just so you know, we are, in terms of trying to support you on that, because we do and have heard your concerns. For those who don't know, we meet with the Provider Coalition on a regular basis, as well as we take concerns as they come in real time often. So we hear you.
Can you confirm if DC Health is recommending that all staff providing any in-person service needs to be tested. If so, how frequently? Where's the best location to look for the screening requirements set by DC Health?
Currently, the last guidance was that testing was to be done for ICFs or other long-term care facilities as weekly. And the guidance is on the coronavirus.dc.gov website. If we could get one of our team members to post that in the chat box, that would be great. But yes, all of the guidances on testing and PPE are listed on that website. And I got a question that came in. Through my email just now. How can the PPP usage disqualify getting a retainer when a retainer payment does not consider reimbursement for the DSP wage element of lost revenue and the PPP is expressly dedicated for that expense? That's a question that we have to follow the CMS guidance. So what I'll do is I will pose that to DACF to have them pose that question to the CMS representatives, and we'll get back to you on that answer. Also have another question that came in online. It's the same question repeated. So yes, okay. All right.
It looks like we have a comment. Not sure if it's a comment or a question. The retainer payment is for 90 individual service days, not 90 consecutive calendar days.
That is correct.
And what happens after the 90 days, since we're clearly past 90 days now?
Well, what happens is that the ability to bill for the retainer rate ends. And as Director Reese has repeated several times, that is when the expectation that providers would use some of those additional resources, if available, to maintain their business model. We recognize that this is a difficult time for people who are in the, business of providing day services and unable to maintain it. We do. We took that into account by including that into our our submitted Appendix K. Initially, we were approved for much more time than 90 days, but what we believe is a change made because the resources are probably in a, CMS has to be thoughtful about how it manages its resources, and thus they limited that to 90 days. And we hear you, but we also know that there are other resources that people can apply for and hopefully be able to get. We have heard that it is a comprehensive process, and we also heard that providers are working together to support providers who may not necessarily have the acumen or the resources to be able to submit and apply for those additional resources. So, we'll continue to have this discussion with the Provider Coalition as to what resources that they can provide to others, because we recognize some smaller providers don't have the infrastructure nor the staffing to be able to navigate through these complex processes of submitting for these funds.
And Sharon Mebane from DC Health just clarified that universal masking and eye protection are required by all healthcare personnel to include res-habs.
Hi, can you hear me? Hello?
Yes.
Okay. So I have Dr. Sharon Lewis here with me. She is the Senior Deputy Director for HRLA and DC Health. So,
And good afternoon, and thank you for this opportunity just to interject. This guidance that was developed by our EPI and made available and placed on our COVID um, website was placed on September the 15th. And we are requiring all of our healthcare providers to follow this guidance for the healthcare personnel in wearing the appropriate mask. I think that you may or may not be aware that as we continue to do our inspections, that we have had some instances where there's been major concerns and even immediate jeopardies identified where masking was not appropriate. And most importantly, we definitely want to protect that healthcare worker. And so I am asking that all of our facilities do abide by this guidance that has been placed on our website. Are there any questions to that?
Yeah, Dr. Lewis, could you just clarify when you say the settings that you're referring to, you're talking about ICFs and RESABs, correct?
This particular document is in regards to healthcare personnel in general. So what provider type are you excluding from that?
Well, Sharon and I had a brief discussion about the definition of healthcare worker. So what I'm saying to you is the ICFs are licensed and the residential habilitations are licensed, as well as the nursing homes are licensed. Are you saying that any type of setting that supports people that you're considering those staff healthcare workers?
Yeah, so any of those settings where we have healthcare workers, and definitely for all of those that we do license, but any of those settings where we have healthcare workers, they should be following this guideline.
So well, I guess we can talk
Providing.
offline. All right.
Pardon me?
No, I guess we could talk offline because the written guidance that was issued the other day was from what I read was the ICFs and RESAB regarding the the eye covering.
no, there was new guidance, as Dr. Lewis said, issued on September the 15th that made it clear as to who is required to wear a face mask. Also, it goes into testing. I know it was a question regarding testing. That's also very clearly outlined within this document. And I'm planning to like to refer everyone to coronavirus.gov, but I will also send it out to all of my licensed providers.
Again, you mentioned licensed providers.
No, they're all, well,
aside from supported living, host home.
Right, I said I would send it out to the ones I have that I have responsibility over, but it goes beyond just the licensees. It goes to all agencies and companies that or facilities that employ people who providing care to an individual, personal care as well as nursing care.
And it says so in the first paragraph, last sentence. This guidance applies to all healthcare settings. So we can send it out in case it's not readily available, and then you can push it out as well. If there's something that we need to discuss after your call, we can do so. But this was posted on September the 15th, 2020.
Okay, thank you.
And I just want to add, I know there was a question, I was muted at the time, regarding visitation. And I just want to let people know that concerns regarding visitation has been brought to DC Health's attention, and our EPI team is reviewing those concerns.
Thank you, guys.
Thank you.
Thank you.
May I just ask if there are any other questions for DC Health while we have them on the line? Can people post that in the chat box now?
Okay. How does all these PPE guidelines affect people in host homes and natural homes?
Are they considered in healthcare settings?
Yeah.
If they're considered healthcare settings, then the guidance do apply.
Hi, and I just want to. So sorry. Can this is Daryl Hawkins from DC Health Epi, and sorry for joining late. I was at a visit, so I'm glad to be able to join. And I just want to echo what Dr. Lewis and Sharon mentioned. I think they clarified it pretty well. Healthcare personnel we define as and again, this is guidance that was just recently updated. We are trying to update the ICF guidance and supported living guidance to then reflect the universal masking and eye protection guidance that is found on this this new updated published guidance. But we define healthcare personnel to be any individuals with either direct or indirect contact and with patients, or in this case, residents or individuals living in these residences who have the potential to be in contact with infectious materials. So with that said, it isn't just those that are providing direct care, although in your setting, that's likely both the case, but it could be any individual in a healthcare setting that that can have indirect contact. So even, for example, I know this doesn't apply to your setting, but it does encompass even those that are, you know, at the front desk, for example, or maybe EVS staff in certain facilities. They're considered healthcare personnel, even though they're not providing direct care. And I hope that gives some clarification. If there is healthcare services being provided, we consider that also to be included in this universal masking and eye protection guidance that was released recently.
Thank you for that.
Yeah, and happy to clarify some more offline too, if providers have more additional comments. But Dr. Lewis and Sharon both did a great job describing the new guidance.
During the August 20 forum, it was stated that there would be a required training for DSPs that will be available as a recorded presentation by DDS, Indoor DC Health, regarding PPE and other safety procedures. It was to be a required training for DSPs that should be refreshed weekly. Has this been made available yet?
So we are just a little delayed in doing this. So we did hold, what we decided to do last week was hold a live presentation, and we mandated that directors of nursing and quality directors participate. However, many providers failed to attend that mandatory presentation. It was recorded, but we just wanted to kind of do it again. So we're going to repeat the presentation live next Thursday, and an invitation will be going out shortly so that we could get more people involved from a quality director and DON standpoint. And so we're going to record that because we want to make sure that we have enough interaction and questions that can be answered as they come up. And we also just need to modify the presentation slightly to reflect this new guidance that has been presented by DC Health. So we will be doing the presentation, as I said, next Thursday, and we'll record that and put that on our website as well as push it out through TIS. And you will then, the instruction is that our directors of nursing and quality directors at provider locations then provide that training to their DSPs. I will not be it is a mandatory training for all DSPs, and the way that we're going to kind of monitor this is going to be through attestation and then just through compliance checks through our QR units. But as of right now, we're going to schedule, as I said, another live presentation on next Thursday. Information will be going out shortly. We'll record that and make that available.
Thank you, Director Dobbs.
I will also releasing, just to follow up, I will also be releasing additional guidance and what the requirements are for that weekly refresher training and the requirements for DSPs. So please just watch for that email. Thanks.
In the original Appendix K from April, it stated initial and annual training, including CPR and first aid, pre-service and in-service training described in DDS policy will be suspended until 45 calendar days after the end of the public health emergency. In preparing to bring DSPs back to day program, is this suspension still in effect, or do DSPs need to renew their CPR first aid and renew their phase 3 and phase 4 training requirements that have lapsed?
So to the extent that a person has the training and it has lapsed, the Appendix K language is clear that we recognize that you may not be able to get them, a recertification prior to the end of the public health emergency. What that means is if they've been certified in CPR and or others, then they can work without those being current, but no one who has the first-time employees, this does not apply to them. So they must have those things prior to working with people served. Simply put, if you're trained in CPR and the actual guidance in CPR has not trained, but you're looking at a card that expired, but you know how to administer CPR, they can continue working. We would also ask that you have your directors of nursing, reinforce certain aspects of the CPR and the first aid to ensure continued competence, but we're not forcing you to have the actual certification dated accordingly. So hopefully I didn't confuse you, but what I'm saying is if a person was certified and that certification expired, take some little time for your directors of nursing, your lead clinicians to ensure that the people maintain that competency or that they are still familiar with that competency and then, move forward. But for first-time employees, that does not apply.
Deputy Woodland, I'll also follow up on that. So QAPMA, in association with our colleagues in Human Resources, we are working on trying to make a lot of these trainings digital and provide them during live presentations via either the Zoom or WebEx platforms. Because what we've realized and come to kind of understand is that this public health emergency will last some time. And so we just need to kind of accommodate these kind of virtual opportunities. When it comes to things like CPR and first aid, we are trying to examine what is available in the public for those kind of options. But what Deputy Woodland did say just now does absolutely apply. But for certain other trainings such as PCT and others of the like, we are trying to work with our team to kind of bring them to a digital platform so that we can start those programs once again. So please just stay tuned. And we're hoping in the coming weeks or months, we will have those going virtual once again.
With regard to DC Health Guidelines dated 9/15, please clarify what alternate care areas mean in this guideline or guidance. Does this refer to staff wearing eye protection while out in the community with the people we support?
I'll defer to DC Health on that.
Hi, this is Daryl Hawkins from DC Health EPI. I think that's a great question.
We can't hear you.
Daryl, are you still there? Okay, well, we will, Daryl comes back and we'll go back to her to answer that question. Because it looks like she's still here, but apparently her audio is gone out. Maybe she can type the answer.
Okay, so we will circle back to you, Daryl. Is there a resource for free face shields or goggles? These are generally pricey items. With the increased cost of PPE in general, the mask and goggles can become a financial burden.
Again, this is another item that I would, if DC Health is still on the line, they may be able to address this. As you know, they were supporting our provider community with PPE that was required at one point. I have not heard mention of them providing goggles and face shields, but I will definitely, if they left the call, put this on our agenda for our Monday meeting.
Okay. And a comment, thank you to DDS for continuing to hold these Friday sessions. They are very helpful.
you know, we definitely appreciate all of the hard work that our teams here at DDS are doing. Um, Special shout out to our provider community who's really had to support this tremendous change and continues to show us how, you know, diverse, unique, and, you know, creative they've been along the way. It really makes me feel good being a part of this effort. I'd like to also thank the family members who've been patient with us as we didn't have a playbook for this pandemic. Like to also thank our advocacy community who's helped us ensure that we've protected people's rights in the name of trying to support them to remain healthy. Our federal P&A for keeping us sharp and keeping us focused on what we are charged to do. I mean, it's been a yeoman's effort. We may not always agree, but I think at the end of the day, we've learned so much together through this process. And thank our partners at, you know, the agencies, Healthcare Finance, DC Health, Department of Behavioral Health, CFSA. You know, we've been working like really well together through these times, and hopefully we'll continue to learn and grow and keep our people safe, and allow them to enjoy the fruits of life that we all do. So.
Are there any additional questions? Or is Daryl Hawkins back on the line?
Sorry if my connection was fading. I went into the office. Did you guys hear my answer on the alternate care sites and outings?
We did not.
Okay, I'm so
No.
sorry. So what I said was that was a very good question. I'm bringing it back to my team when, in terms of how I read that question about alternate care areas, while out in the community is, if that person intended to mean while they're for those that are in supported living or CRFs, when they're with individuals that they're serving out into the community, would those DSPs or other care providers need to wear eye protection, for example? And we will address that. And I don't have an answer for you, but I'll get that clarification. If there is clarification, we'll make sure to put that in the updated CRF and supported living guidance to address that specifically. Thank you.
Daryl, we also have a question. Are there specific types of goggles or eyeglasses that all must wear? Example, safety, chemical impact.
Yes. So I will say that CDC, what is considered eye protection by CDC is a face shield or goggles that are indirectly vented, meaning they don't have holes on them and they're indirectly vented, and provides appropriate splash protection in the event that there's crisis capacity, meaning that a facility has exhausted their current supplier or alternate suppliers, and they've reached out to see if they can get alternative supply of either face shields or goggles. If that's not available, safety glasses are crisis capacity eye protection, but it has to be certain kinds of safety glasses which do not have, which protect the sides of the eyes and the front of the eyes as well. Eye protection is never considered eyeglasses are never considered eye protection. Safety glasses that do not cover the sides of the eyes are not considered eye protection under any crisis capacity or any capacity. And anything with holes or vents that would allow splashes to get into the eyes are not considered eye protection under any either contingency or crisis capacity. And we can certainly give more specific wording to DDS if they want to provide that to providers. But that's the guidance for eye protection and what's considered appropriate eye protection.
Daryl, there's another question in regards to face shields and goggles. Is there a resource for free face shields or goggles, since they can be pretty costly?
Right now, we understand that this is PPE that your providers have not normally pre-COVID purchased previously, and we understand the expense. And I think last week there was a question regarding this as well. as of right now, what we can say is that if a facility had an emergency need and they were not able to procure on their own, that they can reach out to our HEPRA for emergency temporary supply of eye protection that is meant to be a temporary stopgap until they're able to procure those resources. In terms of free supply for just general, we do not have that here at DC Health that I'm aware of. And I believe last week, Director Reese said that DDS does not either.
Just to be clear, eye protection, is it reusable?
So there are the goggles are meant to be reused, but if it is reused, those that are wearing it should be dedicated to one individual, and that they should be trained on the proper cleaning and disinfection of that eye protection for contingency capacity. Some one-time use face shields can be reused, again, dedicated to one individual, and then cleaning and disinfection procedures should be, that people should be trained on how to properly clean and disinfect that eye protection. And CDC does have a very specific guidance on how to, they call it reprocess eye protection, meaning cleaning and disinfecting and then reusing that eye protection.
So what I heard specifically was staff should not be sharing these eye protections.
No, definitely not, no. And it should actually be, we actually encourage individuals to indicate either with a label their name or writing with permanent marker on the strap, for example, that their name on it, so that people don't get confused and wear other people's eye protection, correct? Because even if you clean and disinfect it, that is no longer we want you to consider that as contaminated potentially, and that it should not be shared between individuals, correct?
All right. Well, we are a few minutes over one. Again, we'd like to thank you for the call, and we'll have the follow-up items answered by our next call, or either disseminated throughout our provider community contact for those questions specific to the provider community. Thank you, and remain safe.